Everybody's joining. Good. Okay, I can see folks are starting to sign on. So I think in the interest of time, I think we'll welcome everybody that's logged in and introduce Dr. Smith. I'll just take a moment here to welcome everybody. Good afternoon. Welcome to the iRise and Shine Wellness Collective's webinar series. My name is Jillian Lashota, and I am the founder and executive director of the iRise Above Foundation. Our organization strives for outstanding quality of life, empowerment, and inspirational support for young women diagnosed with breast cancer, both those in remission, all stages, metastatic as well. Our mission is to surround young women with targeted, age-appropriate, and connected health and wellness resources and tools to enable them to rise above the residual effects of breast cancer, heal, and live well. This afternoon, I would like to welcome all of you and our guest speaker, Dr. Karen Smith. Dr. Karen Smith is an Assistant Professor of Oncology at Johns Hopkins University School of Medicine and a member of the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center Women's Malignancy Program. Her clinical practice is based at Sibley Memorial Hospital in Washington, D.C., and focuses on breast cancer care with an emphasis on young women. Her primary research area of interest include patient-reported outcomes, reducing the toxicities of cancer therapies, improving care delivery and reproductive health issues in breast cancer patients. Dr. Smith is the Director of Breast Medical Oncology at Sibley Memorial Hospital and co-director of the Young Women with Breast Cancer program at Kimmel Cancer Center at Johns Hopkins. She received a BA in anthropology at Washington University in St. Louis and then attended medical school at Rush Medical College. She completed her internship and residency in internal medicine at the Hospital of the University of Pennsylvania, and then received an MPH at the Johns Hopkins Bloomberg School of Public Health, followed by a fellowship in medical oncology at Memorial Sloan Kettering Cancer Center in New York. This afternoon, Dr. Smith will be speaking to us about the updates on new medical oncology research for early stage breast cancer. Please type in your questions in the chat box as they come up. And I will ask these on your behalf of Dr. Smith at the end of the presentation. Dr. Smith, I'm honored to have you here. Welcome.
Thank you. Can everybody hear me today? All right. Well, thank you for that wonderful welcome, Jillian. It's a pleasure to join you by Zoom for this webinar. As Jillian indicated, I'm a breast cancer medical oncologist working with the Johns Hopkins program, and I have a particular interest in caring for young women with breast cancer. So today we are going to focus on new updates and key issues as they relate to early stage breast cancer. Jillian, I'm not, okay, here we go. So here is kind of an outline of what we're going to talk about. I'm going to start with some definitions just so we can make sure that we're all on the same page in terms of some of the medical terminology about timing of therapy and the different types of breast cancer, and a brief overview of medical oncology treatments, the kind of categories of treatments that we might use in early stage breast cancer. And then we'll move into updates, and we're going to break it down by the different subtypes of breast cancer. So starting with definitions, a lot of the updates that I'm going to review really relate to breast cancer treatment in a certain phase or timing of the therapy in the disease course. And so I wanted to just make sure that everybody who is on the webinar understands the terminology that I'm going to use. And there are three key words. The first one is adjuvant, the second one is neoadjuvant, and the third one is post-neoadjuvant. So starting with adjuvant systemic therapy, that refers to treatments that are given by a medical oncologist, so medications either by mouth or by vein that are given after surgery. And the aim of those treatments is generally to decrease the chance of the cancer returning later, so to reduce the risk of metastases, of cancer spreading to other body parts after the surgery has been completed. Neoadjuvant systemic therapy refers to the same kinds of treatments, but they're given before surgery. So the word neo means before. When we do those treatments before surgery, we actually have several goals. One of them is to shrink the tumor, and another one is to get a little bit of information about the likelihood of cancer recurrence, because based on what we see in terms of response to the treatment before surgery, that tells us a little bit more later about how risky the situation is. And then we can use that information to help decide about adjuvant treatment, so treatment that we should give after the surgery to decrease. And the other goal of all of this is to decrease the chance of cancer returning, just like with the adjuvant systemic therapy. So we certainly have situations where women receive both neoadjuvant and adjuvant systemic therapy, and we have situations where women receive only adjuvant systemic therapy. The final phrase is post-neoadjuvant systemic therapy, and that kind of overlaps with adjuvant in terms of terminology, but it's basically treatments that are given after surgeries to someone who previously received neoadjuvant treatment. But if you're looking through the literature or reading about it, sometimes you'll see either phrase used. So I wanted to make sure to define all of them and make sure everybody understands. So the next thing to make sure that everybody understands is the different types of breast cancer, because the tumor subtype is what really guides our treatment. So the first key kind of group is hormone receptor positive breast cancer. And as many of you are probably well aware, we take biopsy samples and then we send them to the lab for evaluation. And in addition to confirming that we're dealing with breast cancer, we ask them to check for the hormone receptors for the two female hormones, estrogen and progesterone. And we have clear guidelines and we look at the level of expression of those hormone receptors. And anything greater than 1% counts as hormone receptor positive. That being said, the more positive it is, the more likely that a woman can derive benefit from hormonally based therapies. And often we'll use kind of a 10% or higher as a threshold for that. So the other important type of breast cancer that we're going to talk about is HER2 positive breast cancer. And once again, when we have a breast cancer biopsy sample or a sample from a spot where breast cancer has spread, we test it in the lab to evaluate to see if it is HER2 positive. There are two different types of tests we use, immunohistochemistry and FISH. And I'm showing you here the guidelines from our organizations for defining HER2 positivity. And there's absolutely no reason to memorize it because it's really complicated and really confusing. But I'm just kind of showing it to you so that you kind of understand that the definition of a positive test is based on this complex set of criteria with either one or the other or both meeting the threshold for positivity. And the idea is that if it's HER2 positive, we can see benefit from anti-HER2 therapies. So this is really important information because it tells us whether or not to use that type of therapy. The final type of breast cancer that we're going to talk about and that I'll give you updates on is triple negative breast cancer. And that's very simply negative for all of those markers that we talked about: estrogen receptor negative, progesterone receptor negative, and HER2 negative. So for triple negative breast cancer, we do not use hormonally based therapies or anti-HER2 therapies. So there are a lot of different types of medical oncology treatments that we use for early stage breast cancer. Broadly speaking, they can be grouped into different chemotherapy agents, anti-HER2 therapies, also called HER2 targeted therapies. That is limited to the HER2 positive cancers. Endocrine or hormonal therapies, and that's limited to the hormone receptor positive breast cancers. Cyclin-dependent kinase inhibitors, and we'll talk a little bit about those in a bit. Those are generally limited to the hormone receptor positive breast cancers also. And finally, immunotherapy. That's an area of increasing research in the early stage breast cancer setting, generally in the triple negative setting, and we'll go through some updates on that. So with that background, I'm going to launch into the updates that we will be discussing today, and I'm going to start with triple negative update. And there are three key things that I want to talk about. The first one is the use of a specific type of chemotherapy called a platinum agent in the neoadjuvant setting. So that's before surgery. The second one is the use of immunotherapy, and that is in the neoadjuvant and the adjuvant setting, so before and after surgery. And then the final one is capecitabine, which is a specific chemotherapy, and that's typically given in the post-neoadjuvant setting. So that is someone who's had chemotherapy and surgery already. So let's talk a little bit about why we might want to increase treatments for triple negative breast cancer. So we already have some pretty established standard chemotherapies that we use for triple negative breast cancer, and when we treat in the neoadjuvant space, and that's most often a group of chemotherapies, including an anthracycline and a taxane. Most recently, we have learned that if we find that the cancer is all gone at the time of surgery in someone who has received neoadjuvant chemotherapy first, that the outlook is a lot better, meaning there's a lower chance of cancer recurrence. So we call it a pathologic complete response when the cancer is all gone. And so the less cancer we find, the better. And so if there's a complete response, that's even the best. And so in that graph on the right, you can see different groups based on how much cancer is left behind. On the top in the blue is no cancer left behind, a pathologic complete response. And then yellow is a little bit, gray is a moderate amount, and red is the highest amount. And that's something that the pathologist looks at the time of surgery. And the reason those curves are different is that you can see that the risk of the cancer returning differs, with it being highest with those with the greatest amount of cancer left behind. So while this is concerning news for women who have cancer left behind, it also offers us an opportunity to either increase the treatment that we give beforehand so that we are more likely to have all the cancer be gone at the time of surgery, or to say, okay, now we know that we have a slightly riskier situation when we find cancer left behind. We can use that to identify women who might benefit from extra post-neoadjuvant therapy. So we can refine the therapy and only give it to those women who really need it. So that's the direction that the research for the triple negative breast cancer has been going as of late. So the first question is, should we add a platinum, an additional type of chemotherapy, to the standard backbone of neoadjuvant chemotherapy? And there have been several studies looking at this where everybody got chemotherapy and some people also got a platinum as a part of the chemotherapy regimen. And this is an example of one of the biggest studies called the CALGB 40603 study. And some of you may have heard of it, but basically everybody got chemotherapy and some people got carboplatin also. And then shown on the right, you can see in yellow with red boxes around it, the people who got the carboplatin. And those bars are higher because the likelihood of the cancer being all gone, the likelihood of a pathologic complete response, was higher with the addition of the platinum. And that's been consistently shown in multiple studies. So if you add the platinum to your regular chemotherapy before surgery for triple negative breast cancer, it's more likely that the cancer will be all gone at the time of surgery, and that places the patient who received that regimen into a lower risk category. But adding the carboplatin comes along with a lot of extra toxicity. And the primary problem is low blood cell counts. And for those of you who may have received chemotherapy, you know that with low blood cell counts, sometimes you need transfusions or there's risks of fever and infection. And also there's an inability to give the next cycle of chemotherapy on time if the counts are too low. So sometimes we run into troubles with administering the chemotherapy, and that gives us a little bit of pause as to whether or not we should give carboplatin to everybody. Looking longer term into the future, it's really important to think about whether giving carboplatin at the time of the neoadjuvant therapy really improves long-term outcomes. So does it later on reduce the risk of metastases, and does it overall increase the likelihood that a woman can beat the breast cancer? And we don't have a lot of data on this yet to date, looking at all of the different studies, but shown on those pictures on the right, it tells us that the available data actually does not suggest that adding carboplatin improves the longer term outcomes. So the current recommendation is to kind of think about it on an individual basis. And there are certain women in whom we would recommend adding the carboplatin, particularly if we really want to shrink the cancer and think that that might help with achieving the surgical goals, and if we think that it would be tolerated. But there are many women who we don't need to add the carboplatin, and we prefer not to, and we prefer to do the regular anthracycline and taxane chemotherapy and then make further decisions after we have the surgery and we have the information about whether or not a pathologic complete response was achieved. So another area of research for escalating therapy in the neoadjuvant space for triple negative breast cancer has been the question of immunotherapy. So as many of you may know, immunotherapy is a new type of treatment that kind of harnesses the immune system to fight against the cancer. And it's approved for many different types of cancers and has led to some really amazing outcomes in many different cancers. In breast cancer, we are currently approved to use it for metastatic triple negative breast cancer only. And there's a lot of research going on in earlier stage disease. One important study that recently came out was in the triple negative space in the neoadjuvant setting, and that's the Keynote 522 study. And that study actually had two groups of patients. In the first group, everybody got pembrolizumab, which is the immunotherapy, plus they got carboplatin, which we just talked about, plus they got the standard Taxol or Paclitaxel, followed by an anthracycline and cyclophosphamide. And then they got surgery, and then they got more pembrolizumab in the post-neoadjuvant or adjuvant setting. The control arm just got the chemotherapy, so they got a placebo, which is essentially a saltwater infusion, plus the chemotherapy, and then surgery, and then more of the placebo. So you can see here that there are two main differences. The first one is that they got the immunotherapy before surgery, and the second one is that they got immunotherapy after surgery. And then everybody in this study actually got the carboplatin, which we talked about in the previous study, and that's not necessarily the standard to give to every single patient. Nonetheless, they did have a positive study in terms of the pathologic complete response rate. So the likelihood of the cancer being all gone at the time of surgery was higher, 65% compared to 51% in the pembrolizumab arm. However, we need more follow-up. The early data does suggest that those women who received pembrolizumab before and after surgery had fewer future events, meaning progression before surgery, subsequent recurrence in the breast area, metastasis elsewhere, development of another breast cancer, or passing away. But that's a lot of extra treatment, and we are still, I think, really in the relatively early phases of figuring out which patients need all of this extra treatment and who could cut back and get more the standard chemotherapy and be saved the extra toxicity and the extra burden of all of those infusions even after surgery. And long-term follow-up really is needed to confirm the effect of pembrolizumab on recurrence and survival. We have the solid data for the pathologic complete response, but the survival and recurrence data is not yet mature, meaning we need to wait for longer to be sure of it. So this is not yet approved for use. So something that is approved for use and that we are now using is post-neoadjuvant capecitabine. And the study for this was published a few years ago in the New England Journal of Medicine. And it allowed women with stage 1 through 3 breast cancer who had received neoadjuvant chemotherapy before their surgery and who still had cancer left behind. So they did not have a pathologic complete response. And actually women were allowed to participate if they were triple negative or if they were hormone receptor positive and HER2 negative. However, the main benefits were in the triple negative group, and that's why I'm describing this as we talk about the triple negative updates. Women were randomized to 2 options. Option number 1 was to receive an extra pill chemotherapy called capecitabine, and option number 2 was to receive no further chemotherapy, which is the standard after receipt of a full regimen before surgery. So this is the key finding. You can see on the bottom, with the red box, the women with triple negative disease. On the left is disease-free survival, which largely speaks to recurrence, and on the right is overall survival. And you can see that there is an improvement with the capecitabine arm on top for both groups. And so this has become a real standard for women who receive standard, excuse me, standard chemotherapy for triple negative breast cancer and still have residual disease at the time of surgery. So let's move on now to HER2 positive breast cancer. There are 2 main updates. One is about post-neoadjuvant Ado-Trastuzumab Emtansine, also called TDM1, and another is about de-escalation with a regimen called the APT regimen. So starting with Ado-Trastuzumab Emtansine, just so everybody knows, it's an antibody drug conjugate, which means that it's trastuzumab, which is a HER2 antibody glued to Emtansine or DM1, which is a chemotherapy. And so it's, when it goes in your body, it's targeted delivery of the chemotherapy to HER2 positive cells via that antibody drug conjugate. So this is a study with similar design to the capecitabine study we just talked about, where everybody had neoadjuvant chemotherapy plus HER2 targeted therapy, which is our standard for anything other than very small HER2 positive breast cancers. So they all had that, and then they had surgery. And then we looked and we said, well, was there residual cancer or was there not? For the women who had residual cancer, they were randomized to either complete 1 full year of trastuzumab, which is just that HER2 antibody, or to complete 1 full year of TDM1, the antibody drug conjugate. And these are the results. On the top is the invasive disease-free survival, and then in the middle panel is the freedom from distant recurrence, which is a very important one. That's the metastasis. And on the bottom is the overall survival. And what you can see is that no matter how you looked at it, the Ado-Trastuzumab Emtansine was the winner. And so that has become a new standard for women who have residual disease after HER2 positive breast cancer. So on the one hand, we have been looking at kind of escalating the therapy for HER2 positive breast cancer, kind of with the same idea in mind as when I shared it with you at the beginning of the discussion about triple negative breast cancer, where we want to give the treatment and maximize it as much as possible, try to achieve that pathologic complete response. But if we don't achieve the pathologic complete response, we use that to guide further therapy to identify the women who might have slightly higher risk. And that's been a very successful approach. On the other hand, for women with smaller or lower risk HER2 positive breast cancers, we've really been looking at de-escalating therapy. And by that, I mean giving less treatment, because we recognize that many women with smaller HER2 positive breast cancers have a really great outlook, and that chemotherapy is very toxic, and that the HER2 treatments are actually very successful. So we have identified a group of women who can have less chemotherapy and just focus primarily on the HER2 therapy and still have a really excellent outcome. And that is using the APT regimen, which uses one chemotherapy drug and one HER2 antibody. So Paclitaxel and Trastuzumab. This is given after surgery. So women who have small, node negative, relatively low risk HER2 positive breast cancers do not have to pursue the multi-agent chemotherapy and HER2 therapy before surgery, and don't have to go down that path of figuring out if they have a pathologic complete response and thinking about that. Rather, they can have surgery first. And if they're confirmed to have a stage 1 breast cancer, we can offer them Paclitaxel and Trastuzumab, and you can see here really, really good outcomes. On the left shows all of the cancer patients grouped together who got this regimen, the disease-free survival, the risk of recurrence measured out to 7 years. And since it's way up at the top, you can see that the vast majority of women are not experiencing a recurrence. On the right, it's separated out by hormone receptor status. And you can see that there is a slight splitting of the lines with a slightly higher chance of recurrence or a slightly lower chance of staying disease-free for women with hormone receptor negative disease over time with this regimen. But still, those two lines are really close to the top. So the outcomes are excellent really for all women with stage 1 HER2 positive breast cancer with this regimen. And this has been really great because the toxicity is much lower. So the final group that I want to talk about before we move on to our question and answer session is hormone receptor positive breast cancer. And there are 3 main topics I want to talk about. The first is ovarian suppression. The next is the use of Oncotype Dx, which is a genomic test, and focusing primarily on the use of that in node positive breast cancer. And then adjuvant CDK4/6 inhibitor use. So as many of you may know, there are a lot of different hormonal or endocrine options for premenopausal women, women who have not yet stopped their monthly cycles or who have ovarian function at the time of breast cancer diagnosis. And these are typically given in the adjuvant setting, so after the surgery has been completed. The first one, and the kind of the old-fashioned one, is tamoxifen alone, and that's given historically for 5 years, but there is definitely data now that suggests that 10 years is better than 5 years, and that's just a pill. It's an anti-estrogen agent. It doesn't block your body from making estrogen, but it blocks the effects of the estrogen on the estrogen receptor on cancer cells. The second option is to start with tamoxifen, and over time, if a woman who is premenopausal naturally becomes postmenopausal or becomes surgically postmenopausal, and we're sure about the menopause status, we can think about switching over to an aromatase inhibitor, which is a type of medication that we often use in postmenopausal women and that does not work in the premenopausal setting. The other option is to say, you know, what if we make the premenopausal woman postmenopausal? And you can do that 2 main ways. The first is to suppress the ovarian function with an injection to turn the ovaries off that can be given either once a month or once every 12 weeks. The second is to ablate the ovaries, most often by surgical removal of the ovaries, and that induces a permanent menopause. Once you've done that, the woman is functionally postmenopausal, and you can either give tamoxifen also, or you can give an aromatase inhibitor also. So there's a lot of different choices. The key update with regard to the choice of therapy comes from the SOFT and TEXT trials. And these were 2 trials that tried to figure out the best option for premenopausal women. And this shows how the studies were kind of put together. And shown in the colored part, you can see on the left, the SOFT trial, and there were 3 groups in that one. There was a group that got tamoxifen alone, a group that got tamoxifen plus ovarian suppression, and a group that got exemestane, which is an aromatase inhibitor, plus ovarian suppression. Shown on the right is the TEXT trial, and that had the same design except nobody got tamoxifen alone. And what they did is they ended up putting a lot of the data together and analyzing the 2 data sets together so that we had information from a lot of patients, from over 5,000 women, to guide and inform our decisions moving forward. So this is the most recent update, and it kind of puts all of the data together. And what you can see is that overall, there is a benefit, although quite small, for ovarian function suppression. Some of the lines look like they are kind of close together, especially on the top, which looks at all patients. On the bottom, it looks at patients who received chemotherapy, and you can see that the lines kind of do split apart there. And what that tells us is that while there is really a benefit overall for the ovarian suppression, it's the greatest in women who have higher risk disease, and that's women who generally also receive chemotherapy. And that's really important information for us because receiving the ovarian suppression adds an extra layer of complexity and an extra layer of toxicity and side effects to the treatment. So it doesn't need to be given for everybody, but for women whose disease is a little bit higher risk and whom we've recommended chemotherapy or who have other higher risk features, it suggests that there really is a lot to be gained from pursuing this therapy. There's even, as I'm going to tell you about in a moment, a suggestion that this might be able to take the place of chemotherapy in certain cases. So that brings us forward to the discussion about Oncotype Dx. And many of you may be familiar with this test or may have had it done. Oncotype Dx is one of many tests that can be performed on tumor samples. And it looks at the level of expression of all of these genes here, some of which are related to proliferation or cell growth and invasion and things like that. And the level of expression is converted into a score with a range of scores from 0 to 100. And the score actually gives us two pieces of information. The first bit of information that we learned is that it tells us about the risk of recurrence. So overall, the higher score is prognostic for a higher risk of recurrence. And that's important for us because it helps us understand risk and guide therapy. What we learned from several important trials is that not only does the Oncotype tell us about the prognosis and the risk of recurrence, but it actually tells us about whether or not chemotherapy is useful. So that predicts benefit from chemotherapy. And so this is the design here of the original trial called the TAILOR-X study, which was done in women with hormone receptor positive and node negative patients. And that was reported out a few years ago. But basically in that study, women with very low Oncotype scores, less than or equal to 10, did not receive chemotherapy. Women with scores in the middle, 11 through 25, were randomized by the flip of a coin to chemotherapy or no chemotherapy, and everybody got endocrine therapy. And women with higher scores of 26 or higher definitely got chemotherapy plus endocrine or hormonal therapy. And what the study was really aiming to figure out about was those women in the middle. Did we need chemotherapy? And so could we use a score of 11 to 25 to kind of guide those decisions? And here are the key results in the node negative population. What they found is that hormone therapy alone was not inferior to chemotherapy plus endocrine therapy, the combination, which is a little confusing to understand, kind of a backward sentence, but basically the Oncotype score was predictive of whether or not chemotherapy was going to help. And it tells us that for women who are node negative and have a score less than 26, it's generally okay to omit chemotherapy. But there is a caveat there for the younger women. In women who were less than 50, who had scores 16 to 25, there was a little bit of benefit of chemotherapy seen. And there are some unanswered questions. The first one is, well, why is there benefit of chemotherapy? And is it because one of the effects of chemotherapy is that it's toxic to the ovaries and it turns them off and actually sometimes induces menopause? So is the way that chemotherapy is actually working in this group of women with hormone sensitive breast cancer, is the way that it's working that it's inducing menopause, and then there's less estrogen, and that's driving the benefit and leading to lower risk of cancer recurrence. And if that's the case, could this benefit be achieved by giving ovarian suppression with the shots that I talked about or removing the ovaries instead? That's actually a little bit of an unanswered question still. And we really don't know, should we go ahead and give chemotherapy, or can we just escalate the hormonal therapy like I talked about in the soft and text data? The hard part about the Oncotype study here that I'm sharing with you, the TAILOR-X, is that very few women received ovarian suppression. So the study doesn't really answer that question. Most recently, there's been a very similar study in women with node-positive hormone receptor positive breast cancer. And those women who were allowed to participate had 1 to 3 positive armpit lymph nodes. So women with a lot of positive lymph nodes were not allowed to participate. And it asked the same question: can we use the Oncotype Dx test to figure out if chemotherapy is required? So they got an Oncotype Dx test, and women with a high score were not participants. Everybody got chemo and endocrine therapy. Women with scores of 0 through 25, so the cutoffs were a little bit different from the TAILOR-X, but women with 0 to 25 were randomized to chemo and endocrine therapy or endocrine therapy alone. And the findings were somewhat similar to what we saw in the TAILOR-X study, in that they differed for the pre and post-menopausal women. A word of caution: this has been presented at our most recent San Antonio Breast Cancer Symposium in 2020 in December. It has not yet been published. So these are the results as presented, and we don't yet have all of the details. But what we can see, kind of no matter how you look at it, for invasive disease-free survival, distant recurrence, or overall survival, for the postmenopausal women, if you give endocrine therapy plus chemotherapy or endocrine therapy alone, there wasn't much of a difference. And that suggests that chemotherapy can be omitted in postmenopausal women with 1 to 3 involved armpit lymph nodes and a score on the Oncotype test under 26. And that's great news. It can save a lot of women the toxicity of chemotherapy. In premenopausal women, the results were not so reassuring in terms of omitting chemotherapy. You can see that for each of those endpoints, invasive disease-free survival, distant recurrence, and overall survival, there was a small difference favoring chemotherapy. So that suggests that premenopausal women with 1 to 3 involved armpit lymph nodes and a score under 26 do appear to derive some benefit from chemotherapy, as assessed with the available data in this study. Again, the same question arises: is the reason that the chemotherapy seems to be helping just because it's harming the ovaries? And if so, could this be achieved by ovarian suppression instead? The answer does not yet exist. We're hoping to get it over time. But for now, this is really being decided on an individual basis, with a discussion between each woman and her healthcare provider to kind of decide, well, should we go ahead and do the chemotherapy, or should we kind of up the ante on the hormonal therapy, and can we get the same benefit, or should we do both? So I'm going to move on to the next topic, which is our final topic for discussion, and that is the use of CDK4/6 inhibitors. This is a class of drugs that many of you may be familiar with. They are pills or oral therapies, and there are 3 of them that are available. They're called palbociclib, ribociclib, and abemaciclib. And they were first tested in women with metastatic breast cancer that was hormone receptor positive. And the results have been amazing. They slow progression dramatically, adding years of time for many women before cancer progresses. And they improve survival, the amount of time that women live with metastatic breast cancer as a chronic illness. So it's really, really revolutionized the care of women with hormone receptor positive metastatic breast cancer. Whenever we get a type of medication that is that effective in the metastatic setting, we say, well, wait a sec, should we be giving this to women who have early stage breast cancer in the adjuvant setting after they've had their surgery and any other therapies they're going to get? What if we give it for a short period of time? Would that help decrease the chance of the breast cancer ever returning and becoming metastatic? So far, we have information from 2 studies looking at that specific question, the PALLAS study and the MONARCH-E study. And the results are a little bit confusing because they are different for the 2 different studies. So the first one is the PALLAS study, and that one took women with stage 2 and 3 hormone receptor positive breast cancer who'd had all of their other therapies, and they were randomized to palbociclib for 2 years, plus their ongoing hormonal therapy or the ongoing hormonal therapy by itself. And on the right, you can see the results as they are available thus far. And the key take home here is that those lines, the red for hormone therapy alone and the blue for palbociclib plus hormone therapy, are exactly the same. They overlap. So there was no benefit to adding palbociclib with the available data to date. And that is different from what we see in the MONARCH-E study, which looks at abemaciclib, which was another one of the available CDK4/6 inhibitors. This study was a little bit different in that they enrolled a slightly higher risk group of patients. So women, in order to participate in this study, had hormone receptor positive breast cancer, either with 4 or more positive lymph nodes, or if they had only 1 to 3 positive nodes, they had to meet certain thresholds with regard to tumor size, grade, or Ki-67, which are some other features under the microscope. The randomization was the same, abemaciclib for 2 years plus hormone therapy versus hormone therapy alone. And what you can see here on the right is that the lines split. So the red is hormone therapy alone, and the blue is abemaciclib plus hormone therapy together. The inset is just kind of a magnification, so you can see it a bit more clearly. But there's definitely a difference in terms of the invasive disease-free survival between the 2 arms, favoring the abemaciclib. So this is really confusing. This is really short-term follow-up. We don't know why the results are different between the 2 studies. It's even possible that some of the women participating in this study may actually have had metastatic disease when they signed on and it just wasn't known. We don't know if one drug is actually better than the other. We don't know if it's because the amount of time that we've been following the 2 populations in the 2 studies is different. And we don't know if it's because the women in the MONARCH-E study had higher risk disease or more sensitive disease to abemaciclib or something like that. The other caveat here is that a good number of women in the MONARCH-E study were not able to complete 2 years of abemaciclib, largely because of toxicities and side effects, with the biggest one being diarrhea. So I think that this is a super exciting result, but I think that it's early days. I think there are many women in who I take care of that I'm discussing this with, and I think that there are certainly patients who are interested in taking it and who I think it's a reasonable thing to consider. But I think there are a lot of caveats and a careful, balanced discussion to kind of think about the pros and the cons is the way to go. And I think that longer follow-up is really going to help clarify some of the questions about these 2 studies. There is an additional ongoing study looking at the 3rd CDK4/6 inhibitor, ribociclib, in this setting, and that'll give us even more information. So that's the end of my updates. Just to kind of summarize, we have been making great advances and we're really moving the needle forward in terms of treatment of early stage breast cancer for all the subtypes, triple negative, HER2 positive, and hormone receptor positive. What we are really kind of doing, if I had to sort of try to summarize the general trends that I've described, is that we are trying to individualize the treatment and kind of make it the right treatment for the right patient. So for higher risk disease, we want to give more treatments because we want to decrease that risk. And we are getting better at figuring out whose breast cancer is slightly higher risk. And we have better treatments now to bring that risk down. But for lower risk disease, we want to de-escalate and give less treatment because we are well aware that all of our treatment is associated with toxicities of many kinds. So there's been a real push towards trying to figure out, and it's evolving, but trying to figure out for each individual patient what the level of risk is and what the right types of treatments are. So I will stop there and we can spend the rest of the time answering any questions that you guys have. Thanks so much for your attention, and I hope that this has been a useful overview to you.
Thank you, Dr. Smith. I can't seem to put my video back on because you're the host. So I will read some questions here, unless you can unclick.
I'm happy to, should I stop sharing? Would that work? Or you have to what to do?
That's probably what it is. Yeah, maybe. Let's see. Let's see here. That's okay if you can't start my video. So I'll just read some of these questions. Thank you so much for that informative presentation. There appears to be many advances for early stage breast cancer, which is very hopeful for the future for many of those on this webinar, I'm sure. I'll go to the questions that are listed here. The first question is, there's some differences in the soft/text trials with HER2 positive status. IRC the data, I'm not sure what that means, IIRC the data correctly. Are there any recommendations for triple positive patients, or are there any trials going on to study this?
So that is a great question. Actually, one I just was thinking about yesterday and taking care of an individual patient. And I had the opportunity literally just last night to go back and try to look at some of that data. And it is really hard to figure out. The bottom line is that not a lot of patients with HER2 positive breast cancer were participants in those studies, really a very small subset. And there did appear to be kind of a difference in the benefit of ovarian suppression with regard to HER2 status. That being said, the numbers are very small, so I think it's very hard to be sure that there really is a difference. The other issue is that many women nowadays with HER2 positive breast cancer who have stage 2 or 3 breast cancer, as we talked about, receive neoadjuvant systemic therapy. And then we find out if they have a pathologic complete response or not. And we know that pathologic complete response impacts their longer term risk. That information is not available, at least at this time, from the reported data from soft and text. So we don't really know who got neoadjuvant of the HER2 positives and who didn't. And we don't know of those who did, if they got pathologic complete responses. And we don't know if getting a pathologic complete response or not, how that impacted their risk of recurrence with regard to receipt of each of the different endocrine regimens. So it's really and truly a lot of unanswered questions. My general practice has been not really I don't make different recommendations with regard to hormonal regimens specifically based on HER2 status, because I think that the available data is somewhat limited, as I just kind of described. We do know that overall women with higher risk disease do benefit from ovarian suppression. And we do know that in particular, I didn't show a slide on this, young women seem to get the greatest benefit from ovarian suppression. So I think that's a limitation in the available data. It's a really great question, though, and I am hopeful, and I do think that the soft and text teams do plan to report out some additional data from the HER2 positive subset over time, but I don't think it is available yet.
Great, thank you. The next question we have, are there long-term repercussions as a result of switching from tamoxifen to Arimidex during the 5-year period following breast cancer treatment?
So Arimidex or anastrozole is one of the aromatase inhibitors. And aromatase inhibitors only work for women who are postmenopausal. Tamoxifen has efficacy in both pre and postmenopausal women. So if a woman is going to switch from tamoxifen to an aromatase inhibitor, and she is not on ovarian suppression or has not had her ovaries removed, it's very important to make sure with her doctor that we're confident that she is postmenopausal, because the aromatase inhibitor is not effective otherwise. Short of that, there are no other major considerations other than side effects that I would say. So the side effect profile of tamoxifen and the aromatase inhibitors does differ. And so that's something that a woman would want to speak to her doctor about carefully and pick the right approach for herself.
Okay, I'll move to the next question. Are there trials planned or ongoing to compare pre-menopausal women with Oncotype 11 to 25 treated with chemo and endocrine therapy versus ovarian suppression and endocrine therapy?
I wish. There is not a trial in development addressing this specifically that I am aware of. This data regarding from the RxPonder trial that I just shared with you, in particular, the node positive one is very recent. And I think as oncologists, we're all still kind of getting our head around this for women who are premenopausal. And, the hard part about these studies, as you can imagine, is that they take many, many years to do. It takes a long time to design and a study and get it up and running and to enroll patients. And then with hormone receptor positive breast cancer, it takes a very long time to get the results, because the vast majority of women do really well and don't have a recurrence. And in order to get the results, we have to wait for a certain number of women to have a recurrence in order to say, well, this arm was better than this arm, or there was no difference. So it would take years to find that out. So I don't know exactly where the field is going to go in terms of that, but I wish we had that data, definitely.
Okay, the next question is a two-part question. With triple negative breast cancer and neoadjuvant treatment, what are the requirements or conditions to try the immunotherapy post-surgery? And second part, when should a premenopausal woman be asking for this with her physician?
So for triple negative breast cancer, the this is referring to the immunotherapy regimen, so the Keynote study that we discussed specifically. So that regimen is not yet FDA approved. There was actually a big meeting with the FDA within the past few months where this data was presented. And the thinking is that we really do need longer term follow-up. And it is not currently in the treatment guidelines. So at this point, I don't think it represents a standard of care until we get more information. And I think that statement applies to premenopausal and to postmenopausal women. That may change with time as we get a little bit longer term follow-up. And if it ultimately does become a standard of care, I think I would really limit it to the group of women who were allowed to participate in the study, which identifies a group of women who have relatively high risk triple negative disease, because it involves a lot of escalation of therapy. So it adds an extra chemotherapy agent, and it adds the immunotherapy before and after. And so it adds the toxicities of chemotherapy that we talked about, and it adds the toxicities of immunotherapy, which we actually did not talk about. And that's a whole different set of toxicities, largely related to the body attacking itself, because it kind of revs up the immune system. So I am very excited about this regimen, but I think we're not quite ready yet.
The next question is, what are the pros and cons of ovarian suppression versus ablation? Should ablation be considered for women in their 40s since potentially closer to menopause?
So I think it really needs to be decided on an individual basis. Ovarian suppression is the injections that we talked about, and ovarian ablation is typically done by surgical removal of the ovaries, although it can be done via radiation, which is an option fewer women would choose. You know, ovarian ablation, surgical removal, is not reversible. So once you have your ovaries out, that's it, you're postmenopausal forever. Ovarian suppression with the injections is reversible, meaning you stop the injections and most often the ovarian function will return over time. So a big part of it is whether or not a woman wants to go through surgery and whether or not a woman wants to be permanently menopausal. The other factor is convenience. Do you want to be on the shots in the long term? The other issue is whether or not the shots are quite as effective. If you look at data, I believe from the SOFT study, they looked at estrogen levels because in theory, if you're getting the suppression, your estrogen levels should be pretty much blocked. And there was a certain amount of breakthrough, meaning some women did have breakthrough of the estrogen levels. And there is certainly concern that that could lead to less efficacy of the treatment. That actually hasn't been proven as of yet, but that is of concern. So I typically will have kind of a balanced discussion with each of my patients and think about all of those factors and then kind of make the right choice for each patient. It's not a permanent choice if you suggest the suppression, and you can change your mind. So if a woman starts with the suppression and decides she wants to get her ovaries out, that's okay. You can stop the suppression and have the surgery. So the decision doesn't have to be permanent right away.
The next question is, where does presence of lymphovascular invasion come in terms of assessing high risk?
So lymphovascular invasion is when you look at the pathology, the biopsy report, and you see evidence of kind of cancer in the lymphatic or which are the lymph vessels or the blood vessels. That is, it doesn't factor into staging, so it's not sort of a formal high risk feature, but it just gives us an idea that the cancer is kind of a little bit more aggressive and has a little bit more of a propensity to spread. And we often do see it when there is lymph node involvement. So I certainly consider it, but sort of more in a kind of gestalt or subjective kind of way in terms of assessing risk.
Okay, we have a few more questions. The next is, are there any studies occurring for patients with inflammatory breast cancer?
There most definitely are, and there's plenty. It's not something that I could summarize for you, but I would direct you to clinicaltrials.gov. And if you type in inflammatory breast cancer and even further information such as the tumor subtype, that will be able to give you a great list.
Great. Another question, should a should a stage 1A patient with node negative still get Oncotype Dx score even if her oncologist believes she does not need chemo and only needs tamoxifen?
So that's a great question, and it gets kind of at what I was talking about in terms of de-escalating and giving less therapy, and how do we identify low-risk women and not worry about thinking about extra treatments like chemotherapy in them. In general, so stage 1A is the earliest part of stage 1 breast cancer. Those are very small tumors. In general, if the breast cancer is very low risk based on the pathologic features, so it's very small, low grade, things like that, often we don't need an Oncotype test. I think it's very reasonable to get an Oncotype test in a tumor that is larger than 0.5 centimeter in a woman who would be willing or interested in considering chemotherapy if the test suggested benefit. But for a smaller tumor or a woman in whom chemotherapy is not on the table for various reasons, such as other health conditions or things like that, I think it's reasonable to omit Oncotype. I think these things really, just like everything else I talked about, should be decided on an individual basis through discussion with each patient and her doctor to figure out the right path forward. And because it's not one size fits all.
Great. One last question for you, and this is from me, Dr. Smith. At iRise Above, we promote living well after breast cancer by really taking a holistic approach to health and wellness after diagnosis. And this includes, targeted nutrition, really making physical fitness part of your daily regimen, cultivating a healthy mindset and developing a support network with a community of women who have like experiences. Can you speak a little bit about the benefits of doing this this sort of thing with respect to improvements in reported outcomes and reducing toxicity after cancer treatments?
Yeah, I totally agree with you, is the gist of it. I think that there's definitely data in terms of exercise. So for example, exercise helps decrease a lot of the hormonal therapy side effects like joint pains and things like that. I think that there is data in terms of weight as it relates to breast cancer recurrence, and there is an ongoing study looking at a weight loss intervention to see if that decreases the risk of cancer recurrence. I don't know of data specifically with regard to one type of diet versus another improving, in terms of high quality, randomized trials demonstrating that it improves outcomes, but I really do find that my patients feel better when they eat right and when they exercise, and that impacts absolutely everything. And I fully agree in terms of just the general benefits all around of support and community.
Well, I have a second part to that question, if I can, as the last question here. I have metastatic breast cancer and I've been thriving this is my 5th year, and I continue to do better over time. And I was part of the Johns Hopkins Metastatic Breast Cancer Clinic that took part, I guess, the end of 2020 and is continuing on. Has there been any discussion of having such a clinic for those in early stage when they, finish their treatments and so forth, to just help them move on the right path to eliminate some of those side effects after treatment and surgery?
So that's a great question. For those of you who don't know, we are piloting a new multidisciplinary metastatic breast cancer clinic called the Hope at Hopkins Clinic. And what it involves is a series of consultations for women living with metastatic breast cancer with the goal of wellness and a holistic approach to living with breast cancer. And women meet with an integrative medicine provider, a physical medicine and rehabilitation provider, a nutritionist if they're interested. We have a navigator, we have a supportive oncologist. Those are the main ones. And we use questionnaires to assess symptoms and kind of refine the set of consultants to meet individual needs for each patient. And we are really excited about it and have gotten great feedback and are hoping that it's really kind of giving women very concrete suggestions for how to live well with breast cancer. I think it's a great suggestion, Jillian, to think about something like that in the adjuvant space. So women who have completed their therapy or are just embarking on the hormonal therapy part of it. We are, right now we often will do sort of a survivorship visit is what we call it, where we address symptoms and kind of think about strategies to move forward. But I think, we'd be certainly open to discussing other ideas for kind of a more comprehensive type of program in that space, because I fully recognize that a lot of women, while cured from their breast cancer, are enduring a lot of ongoing symptoms after the treatment or while receiving the hormonal therapy. And our goal really is to live better during and after treatment. And I think there is room for improvement for everybody.
Yeah, that sounds great. I mean, that was not having that available to me once I finished my treatments and surgeries was really the impetus behind me starting this foundation. Just having those support services available. I felt like only then did I start to process what had happened and really start to feel the side effects of the treatment and felt very adrift. So something like that would be really great in the future for early stage breast cancer. Yeah.
Have great suggestions.
Well, thank you so much for your time today. I really appreciate you being a guest speaker in our webinar series. And if there's any follow-up questions anybody has, please email me and I'll send them on to you, Dr. Smith.
Thanks so much. I hope everyone has a great day. Take care.
Thank you.